Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hello, and welcome to another edition of Research Perch, the podcast of the Massage Therapy Foundation, with your hosts, Ruth Werner and Dr. Geraldine Cameron, coming to you from beautiful downtown Chicago. Actually, you're not in downtown Chicago.
I'm in the suburbs, but that's okay.
Chicagoland. And we are happy to bring you today another article from the International Journal of Therapeutic Massage and Bodywork, the IJTMB, which you can find at ijtmb.org. And we encourage all of our listeners to please check in at the IJTMB and subscribe. How much does that cost? That's like one of the more expensive academic journals on the market right now. Isn't that true, Geraldine?
Yes, it's free 99.
It's free 99. No, it's a very, very important core principle at the Massage Therapy Foundation. At the Massage Therapy Foundation, that the journal, our academic peer-reviewed journal, is free to use and also free to submit to. So if you are a potential author or contributor to the journal, there is no fee for submitting your work for review. And for those of you who are donors to the Massage Therapy Foundation, this is how we put your investment to work. And we feel that the IJTMB is one of the most important services that we can offer to the massage therapy profession. One of the things that we do at the IJTMB that we feel is really important is we publish case reports. And not all journals do that. Case reports, if you're a regular listener, you'll be very familiar with this. They are the stage of documenting our work that really anybody who's in practice can do. It's simply telling the story of what happens between one therapist and one client in a predictable and rigorous and analytical way, and they add great richness to our evidence base. Today's case report, it was a recent winner of our student case report contest. So one of the things I want you to bear in mind as we go through this is that this was written by a student while she was still in school, and the student was Yolanda Casciaro, who went to MacEwan University in Edmonton, Alberta. And we get a lot of winners out of MacEwan University, and you'll hear why today. This is a very rigorous, very ambitious case report, and the topic of it was about a client with Parkinson's disease. So the title is "Massage Therapy Treatment and Outcomes for a Patient with Parkinson's Disease, a case report." So if you are listening and you want to have your own copy of this, then all you need to do is go to ijtmb.org. In the search box, put in Parkinson's disease, and it'll pop right up. Yolanda Casciaro wrote a very ambitious case report dealing with a client who had Parkinson's disease in a very, very severe form. I've done a fair amount of reading about massage therapy in the context of Parkinson's disease, and this is, I could say, is probably by far the most severe version of Parkinson's that I have seen someone begin to write down some things about bodywork with. My filter that I bring to Research Perch is that of someone who's really interested in pathology and how massage and disease interact. So I look at this through the filter of what does she say about Parkinson's disease, and is that accurate, and is this the most current understanding of this condition? And I will say that, she's done a nice job of synopsizing what Parkinson's disease is. This is a central nervous system dysfunction, and that actually turns out to be a really important thing that will have implications when we talk about why she got the results that she got. But what we have in Parkinson's is a problem with movement centers. so that the message is to initiate movement and to balance muscle contractions between prime movers and their antagonists gets messed with. It is considered, well, we understand the sequelae in Parkinson's fairly well, that there's a problem in the basal ganglia and they don't produce enough dopamine, and that it leads to other, there's a problem in the substantia nigra. We don't produce enough dopamine, and that means the basal ganglia can't do their work. What leads to those initial problems with the production of dopamine, we don't understand that yet. And so that's why Parkinson's is sometimes called an idiopathic disease. But what I want you to understand is the net result of Parkinson's are what are sometimes called primary and secondary symptoms. And the primary symptoms are really about fatigue and achiness, resting tremors. If you think about the balance between prime movers and antagonists and how that gets off, what you see is one muscle group will contract, and then the other muscle group will contract, and then one will contract, and the second one will contract. And the net result is resting tremor. That's a tremor when a person is at rest. That tremor tends to disappear when that person tries to do something like pick up or drop their pen or eat or do other things. The definition of resting tremor is it only happens while a person is not focused on some other kind of movement. Resting tremor also tends to disappear while people are sleeping.
I had a great uncle with this, and he had a lot of they call it pill rolling, where his hand keeps going like this, and that's
very, very common.
Signs of it. Mm-hmm.
Yeah. Another primary sign for Parkinson's is the symptom called bradykinesia. And if you take that apart, what it means is Brady is slow and kinesia is movement. So what it sounds like is that they move very slowly. That's not actually true. What it really means is it's very, very difficult for someone with Parkinson's disease to initiate movement, to get started. So they'll often report feeling just absolutely rooted to the floor, and they can't find the nervous impulse to initiate movement. When that finally happens, it tends to have much too much power behind it, and so their center of gravity gets off and they fall. And in fact, this is something that had happened for this person. She'd had a number of falls, and that turns out to be a big risk for people with Parkinson's disease. And then the last big primary symptoms for Parkinson's, so again, this is in addition to pain and fatigue, bradykinesia, or having problems initiating movement, is rigidity. The rigidity is a central nervous system rigidity. It's not being generated because we're stressed or tense. It's being generated because of problems with nerve signalings inside the brain. And in Parkinson's, as with many kinds of motor dysfunctions, the muscles that win tend to be the flexors. So someone with Parkinson's will tend to have a stooped posture. And sometimes we think that this is because they're older. Usually we see Parkinson's in people who are older, and so we're looking at osteoporosis, and that might be part of their picture. But when we do testing to see what the muscle tone is like on the anterior side of the body, we run into this rigidity issue, which it turns out, as we will see, to be particularly challenging to deal with. So all of these primary symptoms then can lead to secondary symptoms about things with insomnia and falling and difficulty with speech and eating, shuffling gait, depression, and mental degeneration is another big piece. And interestingly, in Parkinson's disease, we have two problems. One is the disease itself may lead to some problems with cognition, but two is the drugs used to treat Parkinson's disease definitely lead to problems with cognition. And the other issue with Parkinson's treatment, while we do have some forms of synthetic dopamine that can mitigate some of these symptoms, people tend to develop tolerance for these meds fairly quickly. And so any given medical intervention or pharmacologic intervention that works for Parkinson's is wonderful, but it tends not to work for very long. And so people are constantly in the search for what's going to be the next possible drug intervention that might be successful for them. So that's sort of a thumbnail sketch of Parkinson's disease. It's quite common, and it, as you can imagine, it has tremendous impact on quality of life. And what this student wondered was whether, well, she set out to describe the massage therapy treatment and outcomes for a patient with idiopathic Parkinson's disease who was using massage as an adjunct therapy to help cope with some of the symptoms that she's experiencing. And so there is a history of the use of some kinds of massage therapy in the context of Parkinson's, and what we see is that a lot of people with Parkinson's pursue massage therapy. They like to see if CAM therapies or complementary and integrative health therapies might be helpful for them in combination with their other treatments. But there's not so there's been a small amount of data gathered about this. And one of the things I really, really liked about this case report is that this student created a very nice overview of the existing literature about manual therapies for Parkinson's. And she found some of it applicable for her own use and some of it less so. But one of the things we look for in a case report is how the author looks at the literature and uses that to help form some of their decisions about their treatment options. So I'm going to turn things over to Geraldine now, who can maybe walk us through some of the methods and results that we saw happen here.
Sure. And just to piggyback, I was just looking at the table that she created that summarizes the literature with these 6 different studies. None of them are clinical trials. They all appear to be more case study or case series studies. And so, really and they weren't specific to the type of massage that she described. So that was the purpose of her writing this case report, was to look at her type of treatment over 5 different sessions using this outcome measure, this rating scale, as her outcome measure to see what exactly happened with her client. And so she used something called Parkinson's Disease Rating Scale, called Short Parkinson's Evaluation Scale for Outcomes in Parkinson's Disease. So it's SPES SCOPA. So she used the motor impairment section, which seemed to be the best section for this client. Now, one of the things about case reports is you really have to decide which outcome measures you're going to be using. So whether you use already created outcome measures or you come up with your own is kind of up in the air as to which is best. But using something that's already been developed will help other researchers to get a better understanding of what exactly happened because they're familiar with the questionnaire. So this is not one that I'm familiar with, but I do see that it was validated, which is an important thing. So she was measuring the motor impairment of this client and trying to better understand what exactly was happening in terms of their capability in moving.
Well, and I want to add that the client's goals here, which she did map out clearly, and that's another thing we look for in a case report, is that the therapist understands what the client wants to get out of this. And the client's goals were to deal with, to get relief from rigidity and resting tremors and resulting pain in her back, neck, head, upper thoracic and shoulder area, left hand and foot, and occasionally in her left leg. So really the client's looking for reduction in rigidity, reduction in tremors, and reduction in pain. Mm-hmm. This was compared to some of the other case reports that we look at, this was a fairly short one in the sense that it was really only over a total of 6 weeks or 7 weeks. The first week was the assessment period, and then there were 6 treatments, and at that 6th treatment there was putting together some follow-up data. And that is perfectly reasonable for a case report, especially for a student case report, because they're working within the limitations of what their school clinic can do. But in terms of meeting this patient's goals and outcomes, was probably on the short side.
Mm-hmm. Agreed. And it might have just fit into a class. I mean, considering this was a student, and that's probably what happened with this. The nice thing is she did try and spell out what was happening with the treatment plan. She talked about contraindications for this client and when maybe it wasn't appropriate to do the massage that she had spelled out. She has a nice table that spells out the treatment plan, what was happening supine and side lying, and what exactly was the application of the technique. In the treatment plan table, she talks about outcome. Ruth and I were talking about this earlier, that this is probably more the hopeful outcome or goal of the different positions and techniques applied rather than what truly happened in this, because there's certain things that really couldn't be measured in the client's treatment room.
Yeah, so really it's the hypothesis of what of the mechanistic result of the body work that she's doing. Something I'll add to this that I think again was so ambitious for a student and showed a really nice sensitivity to some of the problems that we see with people who have serious diseases, is this client seemed to really struggle with maintaining healthy blood pressure. She'd have tremendous blood pressure fluctuations, probably related to her medication. And the student identified this as a potential risk, took blood pressure with every session, and made modifications within that session to adapt to this so that the client was not at risk for having a sudden drop in her blood pressure and feeling faint or dizzy or falling off the table or whatever, especially when you combine that with movement disorders. So I thought the student did a really nice job of and she had a very complicated client. This is not like working with with your typical person who comes to a student clinic for their shoulder pain or something. This is someone who was very severely affected by this disease, and the student did a nice job of trying to balance all the possible things that could go wrong, and there were a lot.
And I was getting a little bit, because there was so much to it, I was getting a little bit confused with resting tremors, postural tremors, rigidity, pain. There were a lot of different areas of focus within what was being measured and discussed. And so, at least as I read it a couple of times, I kept going back thinking, okay, now is she talking about rigidity or is she talking about resting tremor or what was exactly happening? But again, it was partially because it was so in depth that she was trying to, the researcher, the student was trying to pull so many different data points out and really fully describe what was happening with this client.
And so the net results were, could be interpreted as being somewhat disappointing. Again, I want to point out that the client's goals were to deal with tremor, rigidity, and pain. And I was sad to see that in her final results, the student did not really report on pain. And I'm not sure why that's true, and I would have liked to have seen that. But she did report on resting tremor, postural tremor, and rigidity. And what we saw, interestingly, is very little impact on rigidity and fairly predictable, not huge, but predictable positive impact on tremor. And we don't really know why that's true. So I want to, go back to our understanding of Parkinson's as a central nervous system disease. These changes about what needs to be tight when and where are being generated in the brain, not in our peripheral proprioceptors like we would see with some other kinds of hypertonicities, say. And so I think the student is shining the light on a really interesting question, which is, why did she seem to have some really nice impact on tremor, but less so on rigidity? And my theory about the rigidity is that she just didn't have a chance to work with them for very long, and that might have begun to unlock a little bit with more time. But I'm intrigued at the results that she got with tremor. And actually, now that I'm saying this makes me think of another case report that we did a podcast on a couple of years ago, probably, where the topic was essential tremor. which is different from Parkinson's disease. And the test that she used to track before and after was to have the client draw a spiral. And so you could see differences in the clarity and the sort of confidence of touch as the client drew the spiral in those two different cases. And so there was, and again, we had some nice positive impact on tremor with a central nervous system issue. And, I think people who are into neurology should look at this and dig into that and go, what's that about? Because, we have this thought that what happens inside the brain is a done deal and we can't really impact it much beyond that. And it turns out probably not to be true. And I'm really, really curious about ways we can explore that. And this case report sort of opens a tiny, tiny little peek into that question.
And I'm really glad you brought up that other case report because, in the way that they measured it was so different and so unique from what a clinical trial would be capable of doing. Which is, exactly why I brought up that in case reports, there's lots of different ways to measure things. It's however you measure it in clinical practice. And so as a clinician, if you have them, drawing circles and looking at that pre and post and over time, then that is what should be reported. It may not be able to be reproducible within a clinical trial setting, but it is something that's very useful within clinical practice if you continually measure that at the baseline and then over time. So that was a wonderful case. And this one, again, it's nice that a certain outcome measure was used that is
it's validated, and people who specialize in Parkinson's at least will know what this is.
And you brought up that, maybe this wasn't enough time to really demonstrate what could happen with continued care. And in the discussion section, the student does talk about potential future research that perhaps a year's duration may potentially be long enough to gauge the effects of regular massage therapy treatments. I don't know if that would be long enough or too long. I mean, that's a really long time to measure treatment, but that may be something that's worthwhile doing.
So we put together a couple of sort of follow-up questions that might accompany your discussion of this case report, because we really want to encourage people to use this podcast, Research Perch, as fodder for, say, a journal club or a discussion group or a coffee get-together or a classroom setting. And so the questions that we came up with on this, there's lots of questions you could ask about this. The ones that really struck me were, why do you think tremor responded better than rigidity? And I would add to that, how do you think that worked? That's a big, foggy area for me. And as Geraldine just said, the author posed in her discussion a lot of questions or recommendations or suggestions for future research. I'm really curious to know, what are your ideas? What questions does this case report make you want to ask? And then lastly, I'd ask, Parkinson's is a fairly common condition, and lots of people with Parkinson's disease will seek out massage therapy as a way to add to their quality of life, or an adjunct to their other treatment options. And so what in this case report might help you make some changes or some decisions or some validations about the work that you currently do if you have clients who have Parkinson's disease? What's useful here for you? Maybe what's less useful here for you? Because that's what case reports allow us to do. They allow us to build on the wisdom of others who have taken the trouble of writing down what they found out. So we would all be enriched if listeners to Research Perch who have clients who have Parkinson's disease wanted to write case reports. Wouldn't it be great to have, a whole handful of published case reports on Parkinson's disease that people could compile and look at and say, that looks really great for this client, and that looks really great for that client. So.
And sometimes case reports demonstrate that nothing happened or that it wasn't beneficial, which is just as important to know, because then you're not going to waste your time in clinical practice doing the same thing, perhaps, And I think it's really important to make sure that we, include those types of case reports out there so that we know this did not work for this type of condition, at least in this client.
So important because all of it, benefits the end user, right? Which is the client. The client benefits from having a therapist who has good information. And sometimes that information is a null effect, which
Right.
is totally legitimate.
But I really encourage you to include some qualitative comments, anything that the patient had to say that was negative or positive. In this case report, I didn't see any of that, but I really wondered, what did the client feel? Did even though maybe the resting tremor was just barely changed, did the client feel better? Was the quality of life better? Or were there other outcomes that perhaps were significantly improved that weren't necessarily measured, but were beneficial that the next person could write about in a case report or a larger study?
Right. Plus, that just humanizes the whole thing, and that's a big advantage that case reports have. Is really they describe the human interaction in a way that a clinical study doesn't. So, we really encourage people to include that. Not just tremor seems to move from a 3 to a 2, but this is how that client felt about that.
Exactly.
Yeah, good. So I want to extend my congratulations to Yolanda Cascallaro for having taken on this very, very ambitious project. And I really want to encourage you, Yolanda, if you're listening, to continue to give us more. Now that you're probably you're in practice now, consider participating in the practitioner case report contest. But definitely, you have the seeds of a very, very ambitious researcher in you, and we want to really encourage you to keep at it.
Agreed. Yes.
Good. Anything else, Geraldine?
Nope. This was an interesting case report, and I hope you all take the time to read it and really study it and have conversations with each other. That's the best way to learn how to read the literature, is to have conversations with others. Even though I've been in the research realm for over 25 years, I still learn a lot from having conversations like today's with Ruth. So thanks, Ruth.
Hey, thank you, Geraldine. All right, and thank you, everybody, for joining us. We'll see you next time.
Bye-bye.
Thank you for joining us for this episode of Research Perch. Please send feedback or questions to perch@massagetherapyfoundation.org. See you next time.